Yes. So my patient XYZ, age 14 years old, male, residing from Ahmednagar, informant self and father, reliability fair. Date of admission was 28th May 2022 and date of examination was 28th May 2022. Presented with the chief complaint of fever from 2 weeks, cough from 2 weeks, chest pain and vomiting since 1 week. The history of
Okay.
presenting in illness, the patient was apparently normal 14 days back when he complained of fever. When he complained of fever, moderate grade, intermittent type, recurrent every 2 to 3 times daily, associated with evening rise of temperature, recovering partially with medication. Patient also complained of cough since 14 days, sudden onset, gradually progressive in nature, associated with sputum production, which is moderate amount, yellowish in color, mucoid in consistency, non-blood tinged, non-foul smelling. Cough is present throughout the day, no relieving or aggravating factor. The patient complained of chest pain on the left side from 1 week, which was insidious in onset, gradually progressed over 1 week, sharp type of pain, aggravated on deep inspiration, coughing, and on sleeping on the on that side of the chest, uh, relieved on sleeping on the opposite side. He also complained of vomiting from 1 week, 1 to 2 episodes per day, usually after taking food containing food particles and sputum, non-projectile, non-bilious, non-blood tinged. It is also associated with swallowing difficulty. There was no history of abdominal pain passing difficulty in passing stools. There was no history of weight loss, headache, convulsions, or any bony tenderness or deformity. When we move back to his past history, there were recurrent episodes of fever, abdominal pain, and vomiting at the age of 7. There were recurrent episodes of again fever, abdominal pain, vomiting at again at the age of 10 when there was a epigastric biopsy conducted and it revealed non-specific adenitis. He was started on ATD for 6 months. Then he again reported at OPD at the age of 12 with oral candidiasis and lymph node biopsy revealed TB adenitis. Developed deep ulcerations which healed to form scar on the left lower limb. Again started on ATT for 6 months and FNEC revealed cold abscess and ulcer revealed gram positive cocci. His family history reveals no chronic illness or TB in the family members. He was born out of second degree consanguineous marriage. His immunization history there revealed that he was not vaccinated for BCG and partially vaccinated with partial immunization history with TD. His dietary history revealed that he has 40% deficient in both protein and carbohydrates collected by pre-illness 24 hours recall method. He's studying in 6th standard with good scholastic performance. Socioeconomic history, he belongs to lower middle class and overcrowding is present. Summary: a 14-year-old boy born out of consanguineous marriage came to medical OPD with chief complaints of fever, cough, and chest pain and vomiting belonging to the lower middle socioeconomic class section, with overcrowding being present at home and with a dietary deficiency of 40% calorie and protein. He has the previous history of recurrent consider the patient is suffering from some chronic systemic illness involving lung parenchyma along with pleuritis due to infective etiology, probably tuberculosis.
All right. Okay. Did he have any history of decreased appetite?
So there was no history of decreased appetite as such, but there was vomiting
All right.
associated.
Okay, fine. And you are saying he had a chest pain on his left side, right?
Yes, sir.
And it was non-radiating, right?
So it was a non-radiating pain. It was
Okay.
relieved.
And it was relieved on lying on the opposite side.
Yes,
So
sir.
basically, you are thinking it's a pleural effusion or a pleural pathology, right? Okay.
Yes, sir.
And it is increasing on deep inspiration, right?
Uh,
Hello?
yes, sir. It is
Yeah,
increasing on
it's increasing on deep inspiration. So, what do you think? You are thinking in lines of a tubercular pleural effusion, right? Basically, that's what
yes,
you're
sir.
planning to say. Okay. And you mentioned that he had a history of tuberculosis when an epigastric biopsy was done and he took an anti-tuberculous therapy was of 6 months. So at the end of 6 months, was he declared cured? I mean, initially
He
they
didn't
would have
keep
been,
up to the treatment as such.
did he default the treatment or did he complete that 6 months of treatment properly? What did he give you as the history?
So when we asked him about his ulcerations, he told that once the ulceration was healed, because of which he had ATT,
No, no,
he told that once the ulcer
no, no,
was healed.
I'm not talking about, hello, hello.
Yes, sir.
Yeah, I'm not talking about the ulceration part. There was one epigastric biopsy which you told, right? The for initially when you took ATT, right? The initial anti-tuberculous therapy.
Yes, sir.
The yeah, the no, the next slide. That one at the age of 10 years, right?
Yes, sir.
Hello. Yeah. So during that time, he had taken a biopsy, epigastric biopsy. So that would have been mostly a laparoscopy guided, right? Did he mention anything? How was it taken?
So in the reports it was written, I do not know
Uh,
how it was taken, but so in reports
all
it was
right.
written that it was a epigastric biopsy taken and it was non-specific adenitis.
Okay. So basically, what you have to go through here is one thing, one point to be noted here is whenever you're starting a patient on antitubercular therapy for 6 months, right? He had a non-specific adenitis, right? He had an epigastric biopsy. So if you want to say that the patient has cured or recovered, you should always look for a follow-up ultrasound or CT abdomen, right? At the end of 6 months. Okay.
Yes, sir.
Hello. Yeah. So at the end of 6 months, if your what do you say? If your lymph node has decreased in size or the number has decreased or if the size has gone below 1 centimeter, that is when you say that patient has almost recovered from your tuberculosis. Okay. Basically, what happens is the anti-tubercular therapy is usually mentioned for 6 months, but sometimes when you're giving all these extrapulmonary tuberculosis, right? Whatever we are speaking about here, so in such cases, sometimes you might have to extend beyond 6 months. All right.
Yes, sir.
So yeah. So what is the definition of disseminated tuberculosis?
So disseminated tuberculosis can, uh, I think it is either it's miliary tuberculosis or been spread to more than
Okay,
two
two or
organs.
more. Yeah, it's two or more non-contiguous sites. Okay. So that means two lymph nodes which are nearby, you cannot call that as a what is it? Disseminated tuberculosis. The two non-contiguous areas, right? Or two different organs.
Yes, sir.
So, and you are mentioning that he had recurrent episodes of fever, abdominal pain, and vomiting at the age of 7. So, for that, had he taken any medications or any follow up or anything of that sort? Any idea? At the age of 7.
So the so child doesn't have the recall. Even the parents wrote, but his in his reports are there nothing is mentioned about the treatment.
All right. And was he, what does the parents say? How was his, what do you say, dietary history when he was a child? Was he underweight? I mean, his BMI and all, was he underweight when he was young?
So yeah, so his young age, so his antenatal and postnatal history was normal. He was
Okay.
born, he had a normal weight when he was born,
Okay.
more than
Okay.
2.5 kg, and his delivery was vaginal. There wasn't
All
any
right.
complication in that. So, but
Okay.
as of now, his dietary intake has is deficit in calorie and proteins. As of now, sir, as in
Okay.
so 24 hours before the illness.
Okay. Okay. And basically, just go back to the first line in history of presenting illness. Okay. And yeah, you can see the market too. And no, no, next slide. Next slide. This is fine. Next slide. Okay. So moderate grade. What do you mean by moderate grade fever?
So moderate grade fever, as in, so it wasn't very high fever. It was above 98.8 degree Fahrenheit in the evening, and it was not more than 101 degree Fahrenheit.
Okay. But try not mentioning the moderate thing. Huh? Just say if he
Yes,
had
sir.
a fever, whether it was high grade or low grade. Because high grade, whenever you say he has a fever, it's usually associated with chills, right? So that is when you call a fever as high grade. It's better not to mention the word moderate grade, because I know there are some books which gives you a definition of mild, moderate, and severe. But how much of that is acceptable? It's not sure, right? And hello,
Yes, sir.
yeah, and you're saying he had an intermittent type of fever, and it was associated with evening rise of temperature. Right. So that means you are saying he had a temperature spikes in between as well, right? In
Yes,
between the
sir.
day. Okay. And the sputum was yellowish in color, right? No history of any hemoptysis.
There was no blood found in the sputum.
Okay. And in past history, there is no history of pulmonary tuberculosis before this, na? He
So
had
there was
only
no
abdominal
history.
tuberculosis and that lymph node tuberculosis. I mean, whatever is there, the sinus
Yes, sir. There was
formation.
no pulmonary tuberculosis before. Yes, sir.
All right, all right, all right. And his pain aggravated on deep inspiration, and it relieved on moving it to the opposite side. Right, that's what is.
Yes, sir. Yes,
Okay.
sir.
And how was his breathlessness? Did his breathlessness progressively increase over time, or does he have a proper complaint of breathlessness as such?
So there was so there was no breathlessness associated. We asked him about the breathlessness. He reported that there was no breathlessness.
All right. So if the patient, so that is how you differentiate between what do you say, a malignant or a tubercular pleural effusion from an infective pleural effusion. Infective, what I'm saying is something like an empyema, right? So if it's an
Yes, sir.
infective pleural effusion, patient will have very high grade fever associated with chills, and this pleural pain, I mean, he will have a severe pleuritic type of chest pain, and the pain will aggravate, and he will start developing breathlessness, which doesn't subside because if you don't treat him. The point with tubercular pleural effusion and malignant pleural effusion is it will take a longer time, right? So in this, the patient came to you within 1 week of his chest pain, right? Hello, hello, hello. Can you hear me?
Yes, sir.
Yeah. So he came within 1 week of chest pain, right? The patient.
Yes, sir. Hello. I can hear you, sir. Hello. Yes, sir.
Yeah, yeah. So he came. So that is one history which always goes in favor of tubercular pleural effusion. Okay, or a malignant pleural effusion. But his age is he doesn't have any history of loss of appetite, and his whatever cough history you are giving is mostly of 3 weeks. So malignancy can be ruled out in that way. Okay,
Yes, sir.
all right, and okay, then move over. So just
Uh,
come to your
so
summary.
summary is yes, sir.
Yeah, yeah. So with this like, what do you mean by chronic systemic illness?
So chronic systemic illness is an illness which has been lasting for a lot of duration. So we thought it's a chronic systemic illness because he had some recurrent infections before as well, and
All right. So
and so
basically,
chronic
you're saying
system.
he's immunocompromised, right?
Yes,
Due to
sir.
some, and that is why he's keeping on getting all these infections. And other thing, how what symptoms points to a lung parenchymal involvement?
So since
Hello.
if there is a lung
Your chest
parenchymal
pain. The thing
involvement,
is,
there might be a fever. Uh,
no, fever is a non-specific sign that can be there even if you are upper respiratory tract infection, right? Needn't
yes, sir.
necessarily be right. And someone has actually given the answer in what do you say, the chat box. So you mentioned that the patient has a cough with expectoration, right? So cough with hello,
Yes, sir.
yeah, cough with expectoration is one of the main features of a lung parenchymal involvement. Okay, right,
Yes, sir.
understood. Yeah, so that is what whenever you are giving a summary and you are giving a history, always mention, like whenever you are saying what is involved, you should always give an explanation as to why do you think it's involved. Okay. Your pleuritis is
Yes, sir.
obviously explained. Your pleuritis is obviously explained by your chest pain, which
Chest
aggravates on
pain.
inspiration and increases on the all that aggravating relieving factors. Your chronic systemic illness, it's better to remove it from the, what do you say, from the summary part. All right, just say a chronic.
Yes, sir.
You can't always mention that's a chronic system. It's better not to include that term. All right, and infective etiology, it's fine because it's 3 weeks, and probably tuberculosis is also fine. Uh, just read up what do you mean by tuberculosis suspect?
So tuberculosis suspect can be a patient who has not been who has fever and so as in he's been suspected of TB and not been clinically proven through gram staining or X-ray.
Okay. But there is actually a proper definition, what you call as a TB suspect. Okay.
Yes,
So
sir.
just go through that. I'll tell you some points when you call that a TB suspect. If the patient has a cough greater than 2 weeks, okay, cough with expectorate, cough greater than 2 weeks, and if it's associated with expectoration. Second is any cough in a patient who is HIV positive. All right.
Yes,
Hello?
sir.
Yeah,
Yes,
any
sir.
cough in a patient who is HIV positive, you should always think about tuberculosis. Thirdly, if the patient is in contact with a sputum positive relative, I mean, if there is he is in contact with someone who is sputum positive, you should always think about TB suspect. Okay,
Yes, sir.
so that is a proper. There's a proper. There are other points as well. Just go through. So just read up on why. When do you call it a TB suspect? Okay, and here the thing is. How did he mention that he has taken the anti-tuberculosis therapy for 6 months? Did he give history of any color coding or anything of that sort? There are basically boxes, right?
So, so there are boxes, and so it was written in his report that he had taken ATT.
Okay.
So we
So
didn't
basically, the thing,
ask
one thing you have to,
him
yeah,
like
one thing you have to
how did
notice
he
here
take
is when you are taking a
exactly.
history, when you are presenting a history, uh, thing is you can't you can't mention that it's mentioned in the reports, right? Because when you're taking the history, it's on by the words of the patient, whatever the patient is telling you, right? So during history taking, you can't go through the papers, right?
Yes, sir.
This is okay because you are presenting in a case presentation, but when you are basically what do they say? History of whatever history of presenting illness or whatever history taking is there, it's in the words of the patient, what the patient tells you, right? So if the patient
Ye-
mentions to you the word tuberculosis, well and good, right? You can mention it.
hmm.
The patient told me that he had tuberculosis. So, and while taking the past history, take a clear history as to that epigastric, how was it taken, whether he had a surgery. I mean, he might not be able to tell you that he had a laparoscopy or something. He might just tell you that I had a surgery during which the something was done, and after that the report came out to this thing. I mean, the patient may not be aware because he was young at that time. His parents might be aware of that, right? So while mentioning in the past history, never mentioned, right? If he's mentioning the word tuberculosis, then fine, whatever you are written is fine. But if it's something that you have got from the report, sometimes the examiners may not like it because you are not supposed to go through the reports. Right. Here it's fine because we are having a case discussion. Okay. So
Yes, sir.
just be careful when mentioning that. Okay.
Yes,
Other
sir.
than that, there's nothing much. So your chief complaints is fever, cough, and chest pain. Vomiting is mostly a constitutional symptom here, right? And he
Yes, sir.
doesn't have any abdominal pain or anything. And but he doesn't have any decreased appetite also. Okay. So
Hmm.
one of your differential diagnosis is obviously tuberculosis. Okay. What do you think about lymphoma? Any chances of lymphoma in this patient?
Uh, so lymphomas, if it is lymphoma, then so the cough should have been like there should have been more cough or other than that, so there should have been some significant weight loss as well.
All right, all right. And there should have been decreased appetite as well. So what are the causes you know of pleural effusion?
So pleural effusion can be due to one main cause can be due to TB. It can also
Okay.
happen in pneumonia.
Okay.
And
So basically, hello.
yes, sir.
Yeah. So basically, when you're describing pleural effusion, try to describe it under two headings. Okay. One is transudative pleural effusion, and other is exudative pleural effusion. Right.
Yes,
So when you say transudative pleural effusion, it's more of a systemic disease like your congestive cardiac failure, your liver failure, or your CKD, kidney failures. All right. It's more
hmm.
due to a systemic cause. And when you're exudative, it's more of an infective cause, like a tuberculosis or a parapneumonic effusion, which occurs along with a pneumonia or malignancies. So such cases. So always mention it under transudative and then exudative effusion. Okay. Do you know what
Yes, sir.
light's criteria is?
So light criteria is to differentiate between the exudate and transudate. It's it takes LDH, like amount of LDH and into
So
account or something.
basically it's pleural fluid protein divided by total protein greater than 0.5. Pleural fluid LDH divided by total. I mean the serum LDH greater than 0.6, and your pleural fluid LDH will be greater than two-thirds your total LDH. Okay. So
Yes,
if in this criteria there are three criteria are there in this, at least two of them are there. That means you can call it an exudative pleural effusion. Okay. So and what are the mechanisms of pleural effusion which you know? I mean, why does it occur? Why does effusion occur? Not just effusion, why does an edema occur somewhere in your body?
so
You might be
according to
knowing that. Turning
yes, sir.
causes. Yeah, yeah,
Yes,
yeah, yeah. Tell me.
there can be increase oncotic vessel, or it can be decrease in protein oncotic pressure, or like protein, the
Yeah.
amount of decrease in proteins can lead to edema, or increase in oncotic pressure in the vessels can lead to the edema. um
Okay.
Other than
So
that,
it's
that the
basically
vascular damage can also.
yeah, okay. So basically it's increased hydrostatic pressure. Okay. So this increased hydrostatic pressure is the main cause in your cardiac failure. All right. And the second one, what you call is there's a protein loss. So protein is loss causes a decreased oncotic pressure. Okay. Hello.
Yes,
Can you hear me?
yes, I. Hello,
Hello. Hello.
hello,
Yeah, yeah. There's a bit
hello.
of disturb. Yeah, yeah. There's a bit of disturbance from your side, I guess. Hello.
Yes, sir. Yes, sir.
Yes, sir.
I can hear
Can
you.
you hear me now?
Yeah, yeah. Now I can hear you. Okay. And your third
Yes, sir.
mechanism is lymphatic obstruction. Okay. So that is your main cause in filariasis in which you get edema or a chylothorax. Okay. So basically, if someone asks you
Yes.
what are the three mechanisms of pleural effusion, one is increased hydrostatic pressure, second is decreased oncotic pressure, and third is your lymphatic obstruction. All right.
Yes, sir.
Okay. And so that's it. So that's in base about pleural effusion. And now let's go on to the examination.
Yes, sir. So
All right.
in general examination, we found that the heart rate to be 80 beats per minute, with all
Okay,
central and peripheral
can
pulses
you
were
just
felt.
change? Yeah, one sec. Can you just change the slide? It's still in summary.
Yes, sir.
Yeah,
Wait, so I have changed the slide. Can you see there?
yeah. Change.
So like I have already changed on my laptop. Can there be general physical examination seen on the screen?
No, I'm not able to see it. It's still stuck in summary.
I cannot also.
Yes, sir. So I'll like log
Yeah,
out
yeah.
and do it
This,
once.
yeah, sure. No issues.
Can you see me now? Hello, sir. Can you see my screen?
Yeah, and now I can see it. Just put it on slideshow.
Yes, sir. So general examination, we found that the heart rate 81 beats per minute with good volume, all central and peripheral pulses felt. Respiratory rate
Oh,
90 cycles per minute. Temperature was 100 -2.2 degree Fahrenheit. SpO2 was
Okay.
98% room air. BP was
Okay.
110 70 by 70 mmHg in left upper limb in supine position. All the patient was compliant while carrying out all the general examinations.
Okay. Okay. So one second. One thing I want to ask you is, heart rate. Did you count for the entire 1 minute?
So we calculated for 30 seconds a little bit. It's like there's
Okay. So okay, fine. So if you are calculating it for 30 seconds, how much did you get?
so we got around 11 or 10. It's like
No, I mean now your heart rate is 81, right? What you mentioned.
yes, sir.
Hello.
So heart rate,
So
so to measure heart rate, we had SpO2 attached. So on
okay.
that, so there
All
was
right. Fine. 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 Okay. Otherwise, don't mention for 81 or odd numbers. Okay, because it's
yes,
very
sir.
difficult. Okay.
Yes, sir.
Because whenever you do it, whatever it is, it gets whenever you double it, it mostly comes to an even number, right? It doesn't come up to a odd number.
Yes, sir.
Okay.
Yes.
Okay. So and the respiratory rate is 19. So that means he was not occupied. Right. What's the normal respiratory rate?
So it's for adults it is 15 to around 15. For young, uh, it can be up to 24, 25, and so it
Okay.
increases as the age decreases.
Yeah. Okay. So in a younger, if it's a younger age group, even 60 per minute is normal respiratory rate, right? That is how you classify
Yes.
acute respiratory infections in children. And he was febrile at the time of examination, and pulse rate was 98. Okay, go to the next slide.
So on head examination, there was generalized lymphadenopathy seen with bilateral cervical lymph nodes and also inguinal lymph nodes were there, which could be seen
Okay.
enlarged. Mouth examination revealed white lesions on the inner cheeks and tonsils. Deep ulcerative lesions were observed on the lower limb, which
Oh,
later healed to form scar. Erythema
okay.
nodosum was seen on both the legs. There was no pallor icterus cyanosis or clubbings.
Okay. So what I'm asking you is, you have mentioned bilateral cervical lymph nodes present, right?
Yes,
So
sir.
how was the lymph node? What was the consistency of the lymph node? Was it
So
hard or
uh, so uh, it wasn't hard. It had I forgot to describe the word for that consistency, but
so whenever you are mentioning a lymph node, right? Yeah, one thing you have
yes,
mentioned correctly, you have mentioned the site. Okay. So site, then you have to mention size. Okay. Approximate shape of the lymph node, whatever you feel like. Okay. Site, size,
yes,
shape. Then you have to describe the consistency of the lymph node, whether it's hard or soft. Okay. Then you have to mention if there is any matting of the lymph node. Okay. Why? Because matting of lymph nodes is in tuberculosis. Right.
tuberculosis. So,
Yeah. So mention all that. And just you have to see whether it's tender or not. Also, you have to mention whether lymph node is tender or not. Okay. Because you are mentioning you have
yes,
both cervical lymph nodes and the inguinal lymph nodes. So while mentioning the lymph node, always at least mention the site, size, shape, consistency, whether it's mobile, whether the lymph node is mobile, whether it's attached to the underlying skin or not, whether there is any tenderness, and whether there is any local rise of temperature. Okay, over the skin, and always mention the skin over the lymph node. Okay,
yes, sir.
all right. And
S-
the deep ulcerative lesion which I mentioned on the left lower limb, right, which later healed to form scar. So, what do you mean? That there's an ulcerative lesion or there is a scar there currently?
yes, sir.
Hello, yeah, currently, I didn't get you. Currently, is there a scar or a what is the ulceration?
So currently there's no alteration anymore.
So you just needs to mention there is a heal. I mean, there is a scar. Okay. We know from the history
Yeah.
that it was an ulcerative lesion which formed a scar, but currently at the time of examination, you are seeing only a scar mark, right? Or whatever the healed tissue is there. So you just need to mention this
Yes,
is
sir.
scar mark machine so and so much. I mean, just mention the centimeter also approximately if you can, length and breadth, and it's present on wherever it is. And erythema nodosum is better not to mention as erythema nodosum. Just mention some red colored papillary lesions are present. Okay. What is
Yes, sir.
that you saw? Is that a red color papillary lesion?
Yes, sir. There were red color papular lesions on bilaterally both the legs, and so like small red spots on both the legs.
So basically, one thing you have to notice here is erythema nodosum is a diagnosis, right? Hmm?
Yes, sir.
So you are not supposed to mention that in examination. Just mention reddish papilla. And if someone asks you, what do you think it is, then you can mention the name erythema nodosum. All right.
Yes, sir.
So there's no need to mention the word because that can all be misleading, right?
Hmm.
So what you're saying here is your patient had a pleural effusion, right, in the chest, and now he
Yes,
has
sir.
a skin lesion, and he has erythema nodosum also, right? And mouth examination revealed white lesion. So you think that is a leukoplakia on your cheeks and tonsils, the lesion?
S- so I it can be oral candidiasis or
All right. But yeah, oral candidiasis you have to mostly see on the tongue. Okay,
yes, sir.
it's there in tonsils also. Okay, then okay, and there is no pallor icterus, cyanosis, clubbing, nothing is there. Okay,
Yes, sir.
so if now supposedly I ask you, okay, just imagine the same patient. If the patient had a clubbing, all right, along with all this history, what do you think it is?
So there might be some cardiovascular disease associated with this, but like
Okay, okay. What are the what are the causes of clubbing? Respiratory causes of clubbing, whatever you know.
so pleural pulmonary edema is one of the main cause of clubbing.
I don't think pulmonary edema. Whenever you are mentioning clubbing, one of the main causes you have to always think is bronchiectasis. Okay, one is
Yes, sir.
bronchiectasis. Second is lung carcinoma. It's one of the most common signs which you find in lung carcinoma. All right, and there's something called as interstitial lung diseases and idiopathic pulmonary fibrosis. In that 50 patients, percentage of your patients have clubbing. Okay, and one thing
Yes,
to
sir.
notice here is tuberculosis will never have clubbing. Post-tuberculous bronchiectasis can have clubbing, but tuberculosis having clubbing is rare. And COPD patients will never have clubbing. Okay. So if a
Yes,
COPD
sir.
has clubbing, always think about malignancy.
Okay,
Okay.
sir. Yes, sir.
All right. And then you know your cardiovascular causes are there, and you know GI causes are also there, ulcerative causes, Crohn's. So clubbing as such, I'm not just talking about lung malignancy. For any malignancies, always remember clubbing is I mean, clubbing is one of the signs. Okay.
Yes, sir.
And even what do you think about pallor? Can TB lead to anemia? What do you think?
Uh, s- so pallor can be due to some dietary deficiency if he has, because he already is having he's eating in deficit calories, and
So one thing you have to notice here is that tuberculosis can cause something called as anemia of chronic disease. Okay.
yes, sir.
So that in itself can be an explanation for your if there was a pallor. Okay. And if
Yes.
icterus was present, what do you think? Along with your history of pleural effusion and everything, if there was an icterus present, what do you think it is?
So the liver function has been disturbed, because
So that means okay, that liver function is disturbed, that I understood. So what do you think of the diagnosis person? I mean, what can you think, right? He has a pleural effusion, he has a liver, this thing also. So what do you think?
some multi systems have been involved, or like,
Yeah, it can either point to a disseminated tuberculosis, right?
yes,
It
sir.
can point to disseminated tuberculosis. Secondly, it can point towards sarcoidosis. Although it rarely presents like what they say, icterus, it can be one of the signs. And here you have lymph nodes also, right? Lymph nodes itself is a feature of sarcoidosis, right?
Yes, sir.
Okay. And this cervical lymph nodes which you're mentioning and that inguinal lymph nodes which you're mentioning, if the lymph nodes are hard, there's always a chance of it pointing towards malignancy. So that is why this description of lymph nodes is very important. If it's matted lymph nodes, you can obviously point that to tuberculosis. All right.
Yes, sir.
Okay. So and next time I'll describe in lymph nodes, try to describe it in detail. Okay. And next thing is erythema nodosum. As I told, just describe the location of the lesion and what do you think about the color and all that. All right.
Yes, sir.
Okay. Go to the next slide.
So this is the anthropometric measure where we found height to be little less with 30 centile and weight within 50 centile.
All right. And BMI?
So BMI, I didn't calculate the BMI.
Okay. So instead of these percentile things, it's better to mention it directly in BMI. Okay. Because that is something
Yes, sir.
which helps you directly to show that he's undernourished. Hmm? This
Yes, sir.
percentile thing, you have to go through the chart, right?
Yes, sir.
Basically, went through the chart and found the percentile, right?
So his
So, but
BMI is around 17. I calculated.
yeah, so it's underweight, right? It's
Yes, sir.
underweight for each. Okay. So that is one factor which will always help you in pointing towards tuberculosis. Okay. Go to the next point. Next slide.
So we started his inspection system wise. In respiratory system,
Uh,
we did inspection and we found that trachea was central in position. There was a prominent lower rib cage and symmetrical chest movements were there.
okay. Next one. Trail
So on
sign was negative.
so trail sign was since trachea was in central position, there was no sternocleidomastoid prominence.
All right. And there was any use of accessory muscles of respiration?
So there wasn't visible use of accessory.
Accessory muscles of
Yes,
respiration. Right. And you're saying the chest is moving bilaterally on all areas. Right.
yes, sir.
Okay. And there was no, what do you say? There was no bulge on any side of the chest. There was no flattening on any side of the chest. Right.
So there was no visible bulge.
No visible bulge, no flattening, and there is no visible pulsations or nothing of that sort. No?
No, sir.
All right. Go to the next slide.
So on palpation, trachea was central in position, chest expands symmetrically on both sides. Uh, and on chest expansion, there's expansion of 3 centimeter with a
Hmm.
circumference of 62 centimeters in expiration and 65 in inspiration. Right hemithorax at 61 centimeter, left was right and left hemithorax both were 31 centimeters.
Okay.
There was a reduced vocal fremitus in left inframammary region.
Okay. Memory area. Right? Okay. Next.
Yes, sir. So on
Okay.
percussion, there was dull note present in left in infra axillary, and on auscultation, bilaterally normal vesicular breath sounds with the air entry. Air sounds were heard. There was a decreased sound on left mammary and infra axillary regions.
Okay.
And so
Okay.
vocal resonance, there was decreased in left infra axillary region.
All right. Go back to previous slide.
Yes, sir.
Okay. So inspection, I told you the points, right? Whatever, what else you should have mentioned. Okay. So while doing inspection, you have to look at the trachea. You have mentioned 4 things. Just mention there are no visible pulsations and all that. Okay. And there is
Yes, sir.
something called as a spinoscapular distance. Are you aware of that?
Uh, so I am not aware of it.
Okay. 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 Just go through that. There's something called spinoscapular distance. That is something which you look posteriorly. Okay. That is between the spine of your scapula and your the scapula and your spine. Your vertebral spine is there, right? So that is the
Yes,
distance which you have to see whether it's moving equally on both sides. Okay. So basically, when you have a pleural effusion, your spinoscapular distance is increased, and whenever you have a fibrosis or lung volume loss in the lung, your spinoscapular distance is decreased. Okay. So that is one thing you have to mention. Okay.
yes.
And in what about the this thing, liver dullness in percussion?
So since s- on percussion, so liver dullness was normal. So since the etiology was on left side, we focused on left side.
Okay, but yeah, that is there. But you have to mention everything. Okay. On
Yes, sir.
right side, you have to see the liver dullness and just see how much it expands during whether the liver dullness is shifting down on inspiration. Okay.
Yes,
Alright.
sir. Mm.
And on the left side, there's something called as there's something there is something called as drop space. Okay, TRAUBE. All right,
Yes, sir.
just go through the boundaries of drop space, and you have to mention whether the drop space is usually what the drop space usually contains your stomach. Okay, so stomach usually has a tympanic note, right? So it is
Yes.
usually tympanic. But when you have a pleural effusion, what happens is the thing becomes dull. Okay, so that is something which you have to always mention. Okay, drop space.
Yes,
All right.
sir.
And in percussion,
Yes, sir.
mention your heart also. Hmm?
Yes, sir.
And one thing doesn't, so mention the boundaries of your areas. I mean, rib wise, like you say, like
Some
second to
boundaries of
sixth
the
rib, yeah. Every
so
areas.
okay. Axillary, sorry, apical area. After that, there will be supramammary, inframammary, mammary, and then
Hmm.
axillary will be supraaxillary, infraaxillary. Behind there will be scapular, infrascapular, suprascapular.
Interscapular also. Okay.
Yeah. Yes.
Something called interscapular, and axillary is basically axillary and infraaxillary. You don't mention supraaxillary. Okay.
Yes, sir.
All right. And memory is up to the second, I think it's third or fourth. Just go through that, which intercostal space is there. There's basically a table in which mentions the intercostal spaces, okay, in which you classify these areas. There are clear-cut demarcations. Okay. Uh, how do you do clavicular percussion?
We do without using the left hand. We directly focus on clavicle.
Okay. So by using the left hand, you actually has to pull the skin downwards. Okay. And with the right side, direct percussion on the clavicle. What do you mean by chronic system?
So can you repeat?
Chronic system is KRONIG.
So I do not know about this.
Okay. Just go through that. It's actually something which points to your apex of your lung. Okay. So if
Yes,
there
sir.
is any issue in your apex of the lung, this chronic system is obliterated. It becomes a dull note. Okay. So it corresponds to your apex of the lung. It's something above the clavicle. Okay. So it's a space which is
Yes.
surrounded by your inferior border is your clavicle. Okay. And then you have your scalene muscles. So it is the circular band of resonance which is there. Usually it's resonant because it's the apex of the lung. It has air, right? So it is
Mm.
resonant. But if there's a fibrosis or if there's a volume loss, that becomes obliterated. Okay. So that also you have to mention in percussion. Okay. So in
Yes, sir.
percussion, you should always start with chronic systemus. Then you have to mention your clavicular percussion. Then you have to mention your areas. Now, one thing here which doesn't correlate with your this thing is in palpation, you mentioned there's decreased movement in your infra. Just show the previous thing. Infra maxillary. So you mentioned infra. You were thinking about inframammary, right?
Yes, sir.
Or infra axillary. What is it?
So reduce vocal parameters in infraaxillary.
So it's axillary, right? Not mammary. Okay.
Yes.
Next slide. Okay. So basically, you think there is an effusion in the left infraaxillary, right?
Yes, sir.
So does it come like that? Only infraaxillary.
So no, it might be there anteriorly as well and covering the.
It comes, yeah, it comes mainly posteriorly. Okay.
Yes, sir.
And just another thing which I mentioned is whenever we are mentioning auscultation, you have to look you have written in bilateral normal vesicular breath sounds, and you have to always mention the duration of inspiration and expiration. Okay. In
Yes,
normal
sir.
vesicular breath sound, what is the duration? Which is prolonged, inspiration or expiration?
So inspiration is prolonged.
Prolonged. And what is the difference between vesicular breath sound and a bronchial breath sound?
Uh, s- so vesicular breath. Uh,
Now, there is a
sap-
clear-cut definition. In bronchial breath sound, there is a gap between your inspiration and expiration. Okay. And your
yes, sir.
inspiration and expiration is almost of the same duration. and sometimes expiration may be prolonged also. Okay.
Yes,
And
sir.
what are the different types of bronchial breathing?
So bronchial disease can be bronchiectasis. It
No,
can.
no, bronchial breathing. I'm asking about
Acha.
bronchial breathing. It's a type of, right? Just I told there are two types of breathing. One is vesicular and bronchial. Then there's something called as bronchovesicular also, which is not that important. So bronchial breath sounds there are many types of bronchial breath sounds. Okay. So you have to basically go through that. It's tuberculous, it's tubular and
And
cavernous. Okay.
amphopic, I guess.
Amphoric breath sound. Right. So
Yes, sir.
basically all these are related to cavities. Hmm? And was there any pleural rub present?
So plural.
Pleural rub. Was there any
Uh,
pleural rub present?
so I couldn't appreciate it on auscultation.
All right. All right. All right. Okay. And basically, when you're thinking about an effusion, okay, there is something called a succussion splash, which also you have to do. Okay.
Yes, sir.
To rule out hydropneumothorax, there's something called a succussion splash. You go through YouTube, you'll get the videos on how it looks. Okay.
Yes,
So
sir.
just because we are thinking about a pleural effusion, it can be hydropneumothorax also, right? It needn't be always a pleural effusion. It can be an air, and all your examination findings are in favor of pleural effusion. But always think about a hydropneumothorax also. So basically, if there is a pleural effusion, you should always think about hydropneumothorax. All okay. And there is
Yes, sir.
something called as shifting dullness. You know shifting dullness in the abdomen, right? Which you do for ascites.
Yes, sir.
In the
Yes, sir.
same way, there's something called the chest also, right? Especially if there is a pleural effusion. Okay.
Yes, sir.
So basically, what you do is when you are lying down, you percuss the patient. Okay. And then you get a dull note, just as you
Hmm.
mentioned in axillary area. Then you can either ask the patient to change position, you can ask him to stand. Then what happens is the fluid goes downwards. Okay. So the area becomes resonant. It's just like your, what do you say? Your ascitic
Yes, sir.
shifting dullness. Okay. So that also you can mention. All that is extra points. Okay. And all right. Next slide.
So the other system examination in CVS examination, so S1, S2 was heard. There was no murmur found. Abdo, there was soft, non-tender, and no organomegaly, and there were no specific like in CNS. We did not find any. There was no some
Oh, there
specific
was no
findings.
nonsense. All right. All right. Abdomen also, the liver wasn't palpable, right?
No, sir.
Okay. And your lymph nodes were non-tender, the cervical ones. Was it
The
painful or tender?
so it wasn't painful. It was not tender.
It was non-tender. And was it hard? When you felt it, was it hard or a soft lymph node?
So it
Any
wasn't hard.
analysis? It wasn't hard. So it was midway between what you're saying, it's midway between hard and soft. Something of
Yes, sir.
that sort. All right. Okay. And approximate size
So it
around,
was
was it like
around
a big
point.
lymph node?
So it wasn't very big. It was like around more than 0.5 centimeters.
Okay, fine. All right. Then next slide.
So differential diagnosis. So,
Hmm.
so
Okay.
for it, so the main diagnosis can either it can be some granulomatous disease, TB, or like TB associated with pleural effusion. Then some autosomal dominant hyper IgE syndrome.
Hmm. Okay.
So then the
Yeah,
investigations
yeah.
which were carried.
One sec. Just go to previous slide. Now, give me explanation. Why do you think it's tuberculosis?
So it is tuberculosis because he's having recurrent tuberculosis since before, and other than that,
Okay.
fever. There is fever, chest pain, and evening rise of temperature, which is seen. So it is mostly indicating to TB, and TB can be due to some other causes as well. Like he might have decreased immune.
No, no. What I'm asking is from your history, what points towards TB other than the like I told you earlier, right? Because he has cough for more than 2 weeks, which is associated with expectoration, and he had past history of TB as well.
Yes,
That
sir.
is acceptable. Leprosy, why do you think?
Uh, s- so there are erythema nodosum I told which are seen.
Hmm. Mm.
So it might be indicating to leprosy.
But there is no nerve involvement, right? There is no
Yes, so
local involvement.
there's
There's
no
no
nerve
local
involved.
nerve tenderness, nothing.
No, sir.
There is no loss of sensation also, right? So
Yes.
leprosy as such is something that's not accessed. Sarcoidosis, what do you think?
So because there was lymphadenopathy, lymph node enlargement, we should say.
And your this thing, erythema nodosa, right?
Yes, sir.
Like whatever disc lesions you are mentioning, because there's lung involvement also. But pleural effusion is lesser. I mean, it's not that commonly seen in sarcoidosis. Okay. Do you know the stage of sarcoidosis? X-ray.
So there is a cra- crazy pigment
So there
appearance.
there's actually four stages. Okay. In
Acha.
sarcoidosis, when you're looking at an X-ray, initially you have hilar lymphadenopathy. In second stage, you have a hilar lymphadenopathy along with a lung parenchyma involvement. In third one, you have only lung parenchyma involvement. And in fourth, you have a fibrotic lesion. So there's something called a scalding stage. Okay.
Yes, sir.
All right. So sarcoidosis is accepted, I accept that. And tuberculosis also. And don't mention chronic granulomatous condition. Okay. Because you
Yes,
already
sir.
mentioned tuberculosis is a granulomatous condition, sarcoidosis. The only other granulomatous condition is vaginous granulomatosis or something of that sort. But none of his history which you are given points towards that. Okay. And
Yes, sir.
don't and if he is getting recurrent tuberculosis, what is something which you should always think of other than all this, especially with
So,
Pune and all that?
so immunocompromised state, some
So, which is the first immunocompromised state which you'll always think about? No, this is
s-
okay, but this is something which you look at a later date, right? Very, very later stage. I'm sure even your this thing they wouldn't have gone for this thing, right? Immunocompromised means first thing which you see, which is always associated with tuberculosis and which is the most common cause of tuberculosis in this thing. What do you think?
yes, sir. So we can check him for concurrent HIV infection as well.
Yeah, that's what. So always think about HIV, hmm?
Yes,
Especially
sir.
because in I mean, there are increased rates of HIV patients in Maharashtra. So I was someone who worked there. So most of them are associated with HIV TB infections. Okay. So unless you treat the HIV, he'll keep getting these infections. Okay. And so basically you're saying it's immunocompromised. Now, can his tuberculosis, hello?
Yes, sir.
Yeah, can his new tuberculosis be something which has happened because it was not treated properly earlier? Can it be
Uh,
because he wasn't declared cured initially?
So it might be because of that, or it might be because of the treatment which he was given was not he didn't undergo
It
CB nat, and
wasn't.
some resistance might
Yeah,
have been
that's what.
developed.
That's what. That's what. So that is something which you should always think about. Okay. Now come to the
Yes.
investigations.
So in investigations, X-ray was obviously done, and according to the National Tuberculosis Eradication Program, the sputum sample was taken, and according to his, we found that ESR to be elevated. There were no viral
Mhm.
markers of infection. Ethnicity was normal. Sputum revealed 35 epithelial cells, 30 around 25 epithelial cells, 30% done.
Okay.
MTB was detected, which was rifampicin sensitive. Ophthalmic examination was normal, and a review of his like after reviewing his old record, like which was done around his last episode, the patient underwent one genetic testing for primary immunodeficiency disorder, which revealed interleukin 12 gene deficiency located on chromosome 19p 13.1 with autosomal recessive inheritance.
Okay. And do you have a photo of the X-ray?
So I have a photo of chest X-ray.
Okay. So basically, what do you describe the chest X-ray?
So we can see that this is a non-contrast
No, that is okay.
X-ray
Just
in
come to
PA
the
view,
diagnosis. No, just come to the diagnosis. That's
and we can see
okay.
that the left costochondral yes
Costo,
left costochondral junction is uh, costochondral
cost,
junction is angle has been
costo,
disrupted, and there is
costo,
some
is
whitish
costophrenic
opacity
angle.
which is
Okay.
white phrenic.
Hello?
Yes, phrenic angle. Yes, sir,
Costophrenic angle,
costophrenic.
and there is a cavity also there, right? You can see clearly
Yes, sir.
on the left lower zone, right? And blunting, yeah, there's minor blunting, but that's not a major effusion. Hmm? To cause your that much of decreased breath sound in your infra-axillary area. Okay. Did they do a CT scan or something? No, right?
So CT scan was done before, not this time.
Okay. That also showed a cavity. Any idea? No, no idea. Hello?
Hello, sir.
Hello?
Yes, sir. What was the question? Yes, sir.
So what I'm asking is, so was there a pleural effusion? Was an ultrasound done? Thorax? Because this doesn't look like a too much of
So
a
I
pleural
have
effusion.
no idea about that.
There's a mild
So, but
pleural
there is,
effusion.
so
And
they didn't do a pleural tap.
why?
They said it's not
Because they saw the cavity, right? Or because it was not tappable. Because
it's a hypersensitive this thing, and it might get resolved later.
so that's what. So what I'm asking is, what is the mechanism of pleural effusion in tuberculosis?
So if the so in tuberculosis, it's an exudative pleural effusion, and it usually happens when the granuloma has been formed. If it extends towards the it's near the pleural surface of the lung, then there might be chances of the exudate getting spread in the pleural area.
So that is one mechanism of pleural effusion. There is one more mechanism of pleural effusion. Hello?
Yes, sir.
Yeah, one more mechanism is
So
it
I do
acts
not
as
know
a
of the other
hypersensitivity.
mechanism.
Yeah, the other mechanism is it acts as a hypersensitivity reaction to the tubercular protein because you see a cavity there, right, in your lung.
Yes, sir. Yes, sir.
So there might be proteins which are released from that, and as a hypersensitivity reaction to that, the effusion can develop reactionary effusion. Okay,
Yes, sir.
okay. And what are the other diagnoses which you can have with a cavity? What are the other, what do you say, differential diagnosis of a cavity in lung other than tuberculosis?
So cavity in the lung can be due to aspergilloma, like aspergillus.
All right, fungus,
Then
basically
it
fungus.
can be due to lung abscess. Yes, sir.
Okay.
It can be due to the lung abscess cavitation formed.
Hmm.
Then
Hello, hello.
yes, sir.
Can then what are your
So it can.
do you know of any organism which causes cavitatory pneumonia?
Hello, sir.
Bacteria.
Can you hear me?
Yeah, I can hear you. Cavitatory pneumonia. Do you know any causes, any bacteria which causes cavitatory
Hello.
pneumonia? Hello, can you hear me? Hello,
Yes.
you can hear me, right? Hello.
Yes, sir, we can hear you.
Yeah, okay. Hello.
But network problem for
Yeah.
us.
Okay, fine. So basically, cavitatory pneumonia, one of the causes is Pseudomonas or is Staphylococcus aureus. Okay. So Staphylococcus aureus causes something called as a pneumatocele. So initially there will be a pneumonia and then the pneumonia starts cavitating or necrotizing. So that is a necrotizing pneumonia which can be caused by a Staphylococcus aureus. Another cause is Pseudomonas. Okay. Uh, is he there? Hello? Hello?
Yes, sir, we
Hello?
can hear.
Yeah, okay. So the presenter, is he there? Is he there online?
Yeah, he's there,
Okay,
but
fine.
network problem from them.
His
Yes, sir. So
audio issues are
can
there.
you hear me?
Okay. Yeah, I can hear you. Yeah, tell me. Okay.
Yes, sir. So
Hello?
so there was some
Yeah,
network issue. So what was the question?
okay. No, that is, I already told the answer. Cavitatory pneumonia, one of the most common causes Staphylococcus aureus. Okay, and there is Pseudomonas aeruginosa as well. All right.
Yes, sir.
Okay, okay, okay. So basically, if now supposedly just imagine, okay, the patient here has minor effusion. If he had a moderate pleural effusion, what will be a next step? Hello, hello.
Hello, sir. So
Yeah. Well, if
yes, sir.
there was a moderate if there was a moderate pleural effusion, just imagine what will be a next step. And suppose if the patient was sputum negative, what is the next step which you do?
So if there is moderate pleural effusion and it's sputum negative, then so can we go for directly pleural tap, like drain
Yeah,
the
you can do
fluid?
something called as a thoracocentesis. Okay. So before that, you have to see if moderate pleural effusion and all, it's fine, but you have to get an ultrasound done. And if the size of the pleural effusion is more than 10 millimeter, only then you should attempt a pleural tapping. Okay.
Yes, sir.
And when you're doing a pleural tapping, you should, as I mentioned, lights criteria should be implemented there. So you should send your pleural fluid for protein, LDH, sugars, and everything. Okay. And there's something
Yes,
called
sir.
as adenosine deaminase. Okay, this adenosine deaminase is something which is highly sensitive and specific for tuberculosis. If the patient is ADA negative, that means his chances of getting him having tuberculosis is very very less. All right.
Yes, sir.
Okay. So now tell me the treatment for tuberculosis, tuberculous pleural effusion.
So treatment we can like as per the guidelines we'll start him on ATT, and depending on his CB net report we can go for the second line and third line based on his susceptibility. So other
Okay.
than that, so since this patient
Hello.
so we need to
Hmm.
him on interferon gamma administration as well, because since he has MSMD.
Okay. Fine. So what are the normal? Tell me the intensive and continuation phase in tuberculosis.
So in continuation phase, we remove pyrazinamide. Other than that, we keep HRE for 6 months.
Initial 2 months you give it HRZD, okay, and
HRZE.
4 months you give
Yes, sir.
HRE. All right.
Yes, sir.
Okay. And what are the functions you should monitor when your patient is on all these drugs? What are the blood tests you should do, or what are the
So
symptoms
we
you
should
should
do
look
a, yes, sir. For so
for?
isoniazid, we should look for liver function test for AST ALT
Hmm.
elevation. Other than that, so if the patient is on isoniazids and some neurological complications been developed, we should administer him on pyridoxine vitamin B6.
All right. All right.
And then
Okay.
if ethambutol is also given, so then we need to look for ophthalmic. We should also do a ophthalmic examination, especially in children's. It's recommended that
Okay.
along with ethambutol, should do this.
And pyrazinamide?
Pyrazinamide is regularly given as 10 mg daily
No,
along
no,
with
what I'm
the
asking. No, no, no. That is pyridoxine, right? 20 mg.
okay, sorry, pyrazinamide.
Pyrazinamide, what are the adverse effects? I mean, this is the most common
So
adverse
it
effect.
can cause anemia.
Okay. No, no, most common what I'm asking. Hello?
Yes, sir.
Yeah, so among all of the anti-TB drugs, pyrazinamide is I mean for the regular treatment regimen, pyrazinamide is the most hepatotoxic drug.
Yes, sir.
Okay.
Yes, sir.
And second thing you have to look is hyperuricemia.
Yes, sir.
Hyperuricemia is one of the most common complications associated with pyrazinamide. Now, if a patient, if you are now just imagine your patient, you have started him on AKT, all right, and after 1 month, if the patient starts his liver functions are altered, what do you do?
Uh, s- uh, s-
Hello?
So we'll stop him on hepatotoxic drugs. So okay, so if his liver
Fine.
functions are altered, so we'll all stop all three drugs and we'll try to find which drug has caused the hepatotoxicity the most. So we'll first remove the pyrazinamide, start him in isoniazid, ethambutol, and the other drugs, removing the pyrazinamide. If the patient gets improved, that means the pyrazinamide was the cause. And uh,
So
if
basically, Alex, what we do is we stop all the drugs. Okay. So there are
yes,
two ways of going about it. Okay. Either you can give levofloxacin and ethambutol, okay, and then start
yes,
adding drugs one by one. It is called as desensitization. Okay. So you
yes,
start with INS. Yeah, you start with rifampicin. Okay, rifampicin and INS both are fine, but according to books, rifampicin is the least hepatotoxic compared to INS. So you start with rifampicin. Then initially you give a low dose. Normally your rifampicin is how much per kg? It's 10 mg per kg. Okay. So it comes
yes,
up to the tablet is 450 or 600. So you start with a lower dose of 300, then you go up to 450. And every 3 days you have to monitor your LFT. Okay. Then you start with isoniazid. You go from 150, then you go to 300. And only the at last you have to introduce pyrazinamide. Okay. And next question is uh, hmm, in plural, you are told, right? If you have a do you normally if it's an MDR TB, what is the next line of investigation which you do? Supposedly you do a gene expert. Okay. And gene expert, in your case, it was rifampicin sensitive. Now, if it becomes rifampicin resistance, what's the next step you should do?
so we can go, we can start him on the second line drugs, or like we can go for gene ultra, gene expert ultra.
Okay. Other than that, there's
uh
something more useful than gene expert ultra. Because gene expert ultra, you can initially start, if you're doing a CB-NAT for a patient, and if you have gene expert ultra at your place, directly go for gene expert ultra. Okay. Because it's double cost for the patient, it doesn't give you anything more. All right. So there's something called as
yes,
line probe assay. Okay. So this line probe assay detects the other drugs which
yes,
you have to be given. Okay. So you have to do a line probe assay. And after that, seeing the sensitivity pattern only, you have to start your MDR-TB drugs. All right. Directly don't
yes,
start on.
yes,
Because if you start your therapy and if in your line probe assay something comes resistant, then you have to stop that and you have to introduce something else, right? So it gets complicated. All right.
yes.
And what is the staining which you do for tuberculosis?
So acid fast staining. Then there are other staining methods with the 20% H2SO4. So other than that, we can also go for fluorescent staining. Um,
RMN Rodman. Okay.
yes, sir. Ornament rhodamine.
All right. And what are your culture mediums which you know for tuberculosis? Hello?
Yes, sir.
What are the culture media you are aware of for tuberculosis?
So LJ medium can be used. So then also there
Okay.
is a liquid broth medium also which are available, which is Middlebrook 7H10, 7H2, 7H 9, 11, 10, 12. One will be liquid, other one will be solid with liquid media combined. So other than that, uh, so there's also one
So,
automated
hello?
directly oxygen spectroscopy, which is also there. Yes, sir. Other than that, oxygen spectrometers are also available, sir.
Okay. So, how long does it take for the culture to grow? I mean, how long does mycobacterium tuberculosis take? How long does it take for it to grow in culture?
So it takes usually around 14 days, or like 2 weeks
It
around.
takes it takes up to 6 weeks. In solid
Oh,
media, I'm talking about.
yes,
Okay, in solid media, it takes up to 42 days. Okay, there's something called as MGIT, that is microbacterium growth indicator tube or your BACTEC. So that will give in a mean of 8 to 12 days. That is what you mentioned, the 2 weeks. Okay,
yes, sir.
okay. And what is the full form of CBNAT?
Cartridge-based nucleic acid
Amplification
test.
test. Okay. And you have mentioned that a sputum sample had 30 epithelial cells or something, na?
Yes, sir.
So how much? When do you say it's an adequate sputum sample?
So when there are so there's a ratio which is defined. So beside,
Basically, there are more than 25
I
pulses. That is
forgot.
when you
Hello.
say. Basically, if there are more than 25 pulses, that is when you say your sputum sample is having an infection. Okay, having a growth. All right.
Yes.
Now, you mentioned about gene expert in your sputum. If you are sending your pleural fluid for sputum, how much is the sensitivity? Is it useful to send a pleural fluid for CBNAT or gene expert? What do you think?
So if it is a hypersensitivity induced pleural, hello, sir.
Yeah. Tell me.
Hello, sir.
Yeah,
So
yeah, I
if
can
it
hear you.
is,
Tell me.
it will, if it is hypersensitivity induced pleural effusion, then it won't be able to detect the.
Yeah,
Yes,
that's
sir.
what.
It
So the
won't be able
basic
to
thing
detect
is,
if it is
yeah, that's what.
hypersensitivity induced, but it
Okay.
can be used for
Yeah.
diagnosis.
Okay. So the basic thing
Yeah.
is all your CBNAT, okay? If you are taking it from I mean your pericardial fluid or your ascitic fluid or even your CSF, CBNAT usually have a sensitivity above 90 and a specificity above 90. Okay.
Yes, sir.
Somewhere around in between 85 to 95. But your pleural fluid, it has a very, very low sensitivity of around 30 to 40%. So normally there's no point in sending a pleural sample for gene expert. All right. The only way, hello,
Yes.
the only way
Yes,
you
sir.
diagnose TB in a tuberculosis, I mean, in a pleural effusion, is the cells will have more of a lymphocyte. All right. It will have more of lymphocytes. And there's something which I mentioned, right? ADA, that is known as adenosine deaminase levels. So if the ADA levels are raised, that is mostly tuberculosis. All right.
Yes, sir.
Okay. So that is the way you can diagnose a pleural effusion, tuberculous pleural effusion. Here it's fine because here already you got a sputum positive report of 3 plus. Okay. So that means
Yes.
it's a the effusion is reactionary to your cavitatory agent. So one thing I have to ask you is you mentioned about interleukin 12 beta 1 deficiency, right? Hello? Hello? Hello?
Hello.
Hello?
Yes.
Yeah. So basically you mentioned that Mendelian trait, right? Your interleukin 12 beta 1. Hello?
Yeah. Yes, sir. He has Mendelian susceptibility to mycobacterial
Oh,
diseases with interleukin
so
12
what
or beta
so
1 chain.
what are the most common diseases in which I mean to which these people are susceptible?
Sir.
Hello? Hello, can you hear me?
Yes, sir. Hello.
Yeah, so other than mycobacterial tuberculosis, what are the other diseases to which they are susceptible? I mean, highly susceptible. They'll be susceptible to all diseases, but what are the other infections to which they are highly susceptible? Hello?
Hello.
Can you hear me now?
Ye- Yes, sir.
Yeah, so what are the other diseases to which they are highly susceptible? Other bacterial infections? Hello? Hello?
Yes, sir. So can
Hello?
you repeat? Yes, sir. Can you repeat once?
Yeah, so what are the other infections to which they are highly susceptible?
So they are usually susceptible to both mycobacterial and non-mycobacterial diseases. Since there is no
Ah,
interferon gamma, the immune response cannot be generated against the mycobacterial organisms. And
okay.
so along with that, they also have uh, infections due to other organisms. Usually they are found to have salmonella infection, and then
Candida.
uh,
Candida infections also. Okay.
yes,
So basically what happens is your interferon gamma, right? Interferon gamma always protects you against intracellular pathogens, the bacteria which enters into your cell. Okay. Hello.
yes,
So basically you are highly susceptible to those organisms which enter intracellularly. That is why you are more prone to tuberculosis.